All right, we're going to record the webinar. We'll have it available for you guys, but I wanted to thank you and thank Colleen for including us in this. I want to introduce myself and our company real quick to you. My name is Ikram Masabini. I'm the CEO of MVP Network Consulting. MVP is an IT company. We're a full-service IT company. We include phone systems for businesses and healthcare organizations. We do IT support, cloud computing, and development services. We started a little history of MVP. This is our group. You see in the picture there. We're missing a few in them because this is about 2 years old. So we're missing a few new add-ons. But we're an IT company. We base our solutions around healthcare. We're very healthcare focused. We started in 2002. We have about 40 employees altogether. We focus on setting up infrastructures, working with vendors with HL server interfaces with our development arms, with making sure that your business process works seamlessly for you within your EMR and your PM. And then on the other side, we make sure that you're secure. We do HIPAA audits for you. If you ever get audited, we'll become responsible. We'll become your business associate that manages your entire IT infrastructure. We're open 24 hours a day, 7 days a week, because most of the providers like to call us late to get support, to log in remotely. And we become really your true CIO, where we look at every process that you do, make sure that not only you're compliant, but can we make you more efficient? Can we show you new tools to use to give you that extra edge, that technology edge, to give you that competitive edge, and to provide better patient care, because at the end of the day, it's about patient care. About me, real quick, my name is Ikram Masabini. That's me. So I hope the picture doesn't burn anybody's eyes. But I'm the CEO of MVP Network Consulting. Started the company in 2002. I'm by training an electrical engineer. However, I've been doing healthcare IT for the last 15 years. I do HIPAA consultant and auditing. So I'll come in and audit your entire infrastructure to make sure that you adhere to some of the HIPAA laws. I do IT security auditing as well. I have multiple technical certifications. I can go on and on, whether it being VMware or Microsoft or EagleSoft or Dentrix or MedDent or eClinicalWorks, MedHost, just to name a few. And most importantly to me, I'm a father of two beautiful kids, a 22-year-old and a 4-year-old. So I kept them apart so they don't gang up on me. But I'm excited for you guys to hear this presentation that we have laid out for you. Colleen is an expert, as a lot of you know her. I love her material, and I'm looking forward to some stuff that I will learn from this presentation, and I hope you guys get something out of it as well. Welcome, and without further ado, Colleen Huff.
Thank you, Ikram. Those of you that do know me, I do see a lot of names. Hello to my ADOM friends and my other fellow practice administrators that I know. Those of you that don't know me, I am a fellow. I did get my FADOM last 2015, and I am a working practice administrator. I am still hearing a little background, so I'm just going to do one more quick reminder to make sure you mute either your computer or your phone. And please don't put us on hold, because I guess everyone then hears your hold music. Maybe unless it's some really good, and then we can, listen to it in the background. I have been in the industry I've been working as a practice administrator and in the dental field for about 21 years. A little background, I started at MetLife, and some of the difference that I have than others out there is I did formal classroom training. MetLife did 3 solid months of classroom training, 8 to 5, 5 days a week. So it gave me a little different viewpoint when I started in the field. After that, I went on to work in the dental offices when my husband moved us to New Jersey, and I couldn't go back to work in the dental offices or into the insurance companies, so I went into the offices. I have worked as a bookkeeper, insurance coordinator, and pretty much anything. As you all know, when you're a practice administrator, you do everything down to plumbing sometimes. I am an active member of ADOM. I run the local Buffalo, Western New York ADOM chapter. I did start that, and I'm an ambassador. That is a little background of who I am. I'm currently working in an office, and part of where this presentation came from for me is my own curiosity in having to learn it. A few years ago, the Affordable Care Act started, and most of us in the dental field, I feel, kind of played ostrich and stuck our head in the sand and hoped it would go away. I know I did. And for the first few years, it was pretty easy to figure out who was coming in the door, what they had. Only question you had to ask was, did you buy it in the marketplace? And if they did, for the most practices, it meant we can't take the insurance. That is changing. That has continued to change. And so what I've come up with today is some things that will help you understand what's out there and what you need to ask and what could come in your door. And it is a fluid landscape, and we'll get to some of that. And I do need to preempt this with everything I tell you today can change tomorrow, and a lot of it can change drastically in November. So, but we're going to move forward, and I'll go through what I know, and we'll go from there. So what we're going to cover today, I'm going to give you some new terms and definitions. I felt like I was learning a whole new vernacular when I started researching this, and there's almost like new text messaging. So we'll get to those terms. You're going to understand some of the new plans and how to break them down for your office. I'm going to show you how to find out what's in your state. My first time presenting this, I kept it to the Buffalo, Western New York area. It was really interesting when I started researching around the country, because let me tell you, the states are all completely different. We're going to go through samples of the plans. I am a visual learner. You can tell me all you want verbally what something looks like. I want to see it on paper. So I've got some of those. We're going to review a little bit of reasons to be in a network versus out of network, and what the out of network means to your patient. Because as a whole, there are things that this is going to affect in different ways. And then the last little bit, I'm going to touch on two things that I feel are important and I didn't want to leave out, just some traditional changes to the traditional dental insurances. So let's get going. So let's start with the basics. Your basic landscape in the dental field, I broke it up a little bit, and I have on the left screen of your screen, you see your traditional plans, EPO, DMO, PPO. The term EPO for some of you might be new. That's one of the things I'm going to touch on at the end. There are reduced fee plans. There are still indemnity plans out there. I know we don't see a whole lot of them, but they are there. Your Medicaid managed care plans. And then in different parts of the country, you also have a lot of union plans, and you have also some other like labor plans. The Affordable Care Act is broken into three particular parts. You have standalone, embedded, and bundled. And we're going to get through those definitions today. And if you take nothing away from this, I want you to take away what these three plans are so you have a better understanding of what can come through your door. So what is the Affordable Care Act? We're not here to debate whether it's good, bad, helping people or not. I'm just here to educate you on what it is. So I found myself trying to really figure it out about a year and a half ago. So I went to Medicaid.gov, and this is the definition. The idea behind the Affordable Care Act is to expand coverage for the patients, hold the insurance companies accountable, lower your health care costs, guarantee more choice, and enhance the quality of care. So the idea of the Affordable Care Act did come from a very good place, and we're not going to debate whether it's making that or succeeding. This is just what it's for. So in that, you have various levels. So the Affordable Care Act adopted what is traditional in the insurance industry for other areas of different metal levels. So platinum, gold, silver, and bronze, to help break it up and have you understand a little bit of how they are. So that just gives you a general overview of what they look like. There is someone who's still not muted. If you could mute, please, it would be helpful. Thank you. So what does this mean to us in the dental field? So to me, it was three main points. One, we're going to have a lot more patients walking in our door with coverage. Okay, in the past, they traditionally got them through their insurance company or their employers, or they were maybe on the state plans. Some bought standalone plans, but very few. You're going to have coverage that is more widely varied than you've ever seen before. In the dental, we kind of like our 100% preventive, 80% basic, 50% major. And that has been going away more and more, and this introduction is going to change that even further. And then you also have very minimum coverage. And by that I mean you're going to be covered for your dental on the 4th of July in the middle of the Sahara Desert while riding on the back of a zebra. And I know that sounds a little extreme, but with some of these plans, that's almost how it feels. There is technically coverage, but the actuality of being able to utilize it's not going to happen. So let's start on your basic terms. Okay, we're going to go through Actuary Value, or AV. You're going to learn embedded. We're going to learn what a standalone is, bundled, MOOP or MOOP, and if there's anyone in the insurance industry who can tell me a better way to pronounce it, please call me. QHP, EHB, and now you understand what I'm saying. It's kind of like learning text messaging. And then we're going to touch on what reasonable assurance means. So we're going to jump right in. And your first term is probably the most difficult to understand for all of us that are not sales brokers, insurance brokers. But this is called an actuary value. And I felt this is important because this explains how they get to some of the other parts of the plan. So it's the average share of the total health spending on the essential benefits paid for by the plan. So the Affordable Care Act broke it down into metal levels: bronze, silver, gold, and platinum. The bronze plans having the least generous, and the platinums have the most. So you see percentages on there, and I want all of the the insurance managers out there or practice administrators, don't get very specific on this. It's not a straight, they pay 60, you pay 40. What it means is the average share of what you're going to pay. So on average, a bronze plan, the insurance company pays 60%, the patient's going to pay on average a 40% of their total health spending. And a platinum, the insurance is going to pay a lot more. So in a bronze plan, you're likely to have a higher deductible, higher co-payments, whereas on the platinum plan, you may have a deductible that doesn't have, or there's no deductible on preventive. They may pay basic at 80 or 90%, and a bronze plan may pay basic at 50%. So this is a basic understanding of what they mean, or when you see the term AV or actuary value in reference to how these plans are sold on the marketplace or off the marketplace. The next one we're going to go through is embedded. And this, I think, is the most difficult for us in the dental field. This is going to give you the biggest headache. Unfortunately, this is also coming out more and more. Embedded dental plans are included in the medical policy. Okay, so this means it can be a single deductible with no annual limit applying to both your medical benefits and your dental benefits. You can have a $2,000 deductible. It has to be met before any dental is paid. Let me say that one again, because the first time I read it, I had a hard concept. You may have a child that comes in the door that has to meet a $2,000 out-of-pocket deductible before they pay their dental. Now, in some cases, the medical plans might waive this deductible on dental. Others, they may waive it on the diagnostic and preventive. And some are making a separate deductible. So you see a lot of maybes, coulds, somes, and this is where it's getting very difficult for us to get these breakdowns in and to understand them. Your next term is bundled. And a bundled dental plan is sold together, so a patient pays one premium, but they have a separate medical and a separate dental plan. Now, on the bundled plans, none of those are sold through the exchange. So if someone tells you they bought a plan through the marketplace, it won't have a bundled plan. They're going to be paying two separate policies in one way or the other, okay? And then the last one is the term that, as a whole, I'm hoping we see more of, which is the standalone plan. The standalone dental plan is like our traditional plans. It stands alone separate from medical. You're going to call it a dental insurance company. Things are going to go the way that they're supposed to on that, and it's a little bit easier for us. One of the things to understand, and this goes back to why we talked about actuary value, the government has made rules and regulations that the insurance companies cannot offer anything higher than 85% actuary value. So, and they also have to have no annual limit for the kids, cost sharing that is separate and not integrated with medical. And I apologize for that, and I took some notes out and missed part of it. So what that means is when somebody calls you and says, is this a good plan, it's different than saying, well, it depends on your employer. The government's regulating this. These insurance companies' hands are tied. They cannot offer any better than either a low AV of 70% or a high of 85, and that's it. Okay? So the MOOP or the MOP or I don't know how to say it, the maximum out-of-pocket is the most an individual will pay during a policy period. This is a medical term. This is something that, if you've paid attention, most medical insurances have had over the years, but they're usually such a high out-of-pocket, none of us ever reach them. So once they reach their maximum out-of-pocket on these plans, the plan pays 100%. In 2015, they changed because in 2014, the maximum out-of-pocket for kids on these standalone dental plans was $700. Now, how many kids reach $700? The insurance companies did go back to the government, and they did some finagling with them. So now, a standalone dental plan through the Affordable Care Act has a $350 maximum out-of-pocket. So in English, what that means is your patient comes in, if you have a child that comes in and they have a lot of work to be done, and they end up paying $300, and when they hit the $350 mark, there's going to be no more out-of-pocket. The insurance company is required to pick everything up at 100%. Now, that's not going to happen a lot, I hope. I hope that there's not kids that need that much dental, but it is something to know, and it is something that the insurance companies really did fight for because they felt that it was an unreasonable number. The next thing we're going to go through is the EHB, or the Essential Health Benefits, okay? Part of the Affordable Care Act they came up with in 2014 was they came up with defined benchmarks that are the standards for the essential health benefits. So the 10 categories that have to be included in any plan for it to be legal under the Affordable Care Act are these 10 points. So you have ambulatory services, emergency, hospitalization, maternity, mental health, prescription, rehabilitative and habilitative, say that 3 times fast, laboratory services, preventive, and at the very bottom is where we came into play, pediatric services, including oral and vision care. So most of you out there should know, and if you don't, please learn this today. With the Affordable Care Act, it is now children under the age of 19 must have dental coverage. So part of these EHBs are including that, which is part of where a lot of our embedded plans have come from, okay? The next term we're going to go to is Qualified Health Plan, or QHP. The fun part about this one is when I first saw this term, I called one of the women I know in the industry, and they didn't even know what it meant. So understand and know that a lot of what I'm teaching you today, the insurance companies have had to learn, and their employers. This is all brand new to everybody. But starting in 2014, for an insurance plan to be certified on the health insurance marketplace, it has to include the EHBs, or essential health benefits. It has to follow established limits on cost sharing. So there's established limits like deductibles, copays, and the maximum out-of-pocket. And there are other requirements that must be met. But a qualified health plan will have a certification in each of your marketplace. And when I say that, I mean your state. So we will get to how many states, I believe it's 22, that have their own marketplace. And then within that, those states have come up with guidelines to make them QHP, or qualified health benefits. Again, more control to make sure that all the plans are equal. The other idea behind this is to make sure that a bronze plan is really a bronze plan and a platinum plan is a platinum plan. So there is a set across-the-board ruling. So you can't have one insurance selling a platinum plan and people think they're doing great, but it's really not a very good plan. This last bit I put in there more for the practice administrator part of all of us than anything. There is a new ruling, a new term called reasonable assurance that as managers or as practice administrators, or if there's doctors on the call, that we need to know that if a small employer under 50 employees buys a plan off the exchange, they are required to include an offer of pediatric dental to their employees unless they can document that they have a standalone dental plan, that the employee does. Let me say that again. So all of us, because most of us out there are in offices that are less than 50 people, we have to provide reasonable assurance that a pediatric dental plan has been offered to your employees. They don't have to take it, but you have to have an offering of it. Right now, as it stands, there's nothing that's going to be fined. There's no fines on this yet, but it is coming. It's something that's going to start happening for them, and eventually down the line, we're going to have to prove or send a report, or part of taxes are going to be that we have offered, or maybe it's going to be another report that we as managers have to keep track of. Oh, goody. But there's going to have to be a reasonable assurance that you've done this, okay? So now that that's all said and done, I'm going to do a little overview. So once again, if your health plan includes dental, you pay one monthly premium. In some cases, a separate standalone plans are offered, and if they are, then there's a separate premium. And in the marketplace, dental coverage is included in some, but not in all. So let's really get into, I'm going to do again a little bit on the standalone, bundled, and embedded. These are the three terms that you really have to get down and have a really good understanding when you're doing it. So again, the standalone is a separate policy. This is the one that personally I like because it's a little easier to figure out. There are specific rules. So again, understand that insurance company is under the government regulations with their low or high AV, no annual limit, and cost sharing that is separate and not integrated with the medical. Bundled, they're sold together with the medical, but they're two separate policies, and embedded are included in the medical policy. And again, the embedded are not subject to the same requirements as the standalone and bundled. There's no preset anything, and there's no government regulations on these embedded plans. So let me get to a little bit of what they look like, okay? So this is an example I was given from Delta of a standalone dental plan that was in the Albany area in 2015. It's a DHMO, meaning that it's a dental health maintenance organization, so they are assigned, and there's two levels. So as we do this, I'm just going to try to show you a little bit, kind of go across the board. So here you've got the EHB under the pediatric and then the adult portion. So diagnostic and preventive are the same, sealants are the same, but down here is where you see a little of your difference. Your basic services are $100, the adult pays $120. Major service is $195. The adult is $285.
Alrighty.
And down here you can see your maximum out of pocket per child of $350. Okay, and this is the out-of-pocket maximum is only applied to the PPO dentist. So let me do a little side note here. And this kind of goes to my why to participate. If you aren't a participating dentist, and some of these plans offer out-of-network benefits, most of them, those out-of-network benefits do not go towards this out-of-pocket maximum, meaning there's never any point that they're going to hit it because they won't acknowledge it. Okay? So you can even see what they paid per individual for these plans, okay? There's no deductible, no maximum.
May 11th at 2
There are other things. Someone is not muted again. If they could please, everyone could please check
at 2
for me, I'd appreciate.
Otherwise,
if everyone can check their mute on their phones or their computer.
I'll do an 11 o'clock. Is that better? Okay.
I'm still hearing somebody. I don't think she realizes it. Okay, let's go on. The standalone dental plan, this is a side-by-side comparison, and I kind of like this one because it gives you a really good idea of what they're getting in terms of the 100, what they're getting under the preferred versus the basic. So right off the board, you can see under your basic services, the basic plan's only paying 50%. The major plan pays 80%. And the other part that you look at is the deductible. So you've got a $60 under the preferred, but it's waived in diagnostic and preventative, whereas the other one is $65. So again, high actuary value, you're combined of what you're paying out of pocket, low actuary value. Okay, you're going to pay a little bit more. So again, this is just a sample and gives you an idea.
Sure, will do.
Your bundle plans breakdown fall into the same rules as a standalone plan, okay? There's not a real sample I can give you of what they look like because they look like the ones I just showed you. The difference is in how the patient pays for it. Again, your bundle plans premium are paid with a medical premium, and they are only sold off the exchange. So again, your embedded pediatric dental. Somebody is still not muted. If you could please try to figure out who that is. I don't know. I can't tell. Okay. So again, the pediatric dental embedded plans. There's no guaranteed AV regardless of the tier. So what that can mean is you can buy a platinum plan, okay, that has platinum coverage for medical, yet they're going to have a bronze level coverage for the dentals because there's nothing that is regulated that way. Your typical 180/50 plan could have a $2,000 deductible per child. Diagnostic and preventative are sometimes carved out, sometimes not. But what I wanted to focus on this one is the copays at the very bottom, if you look at the bottom of your screen. So here is something to keep in mind, and this is something very different for us in the dental field, okay? We are not used to a patient walking in the door and having to get a copay from them straight up front. Everybody's used to going to their doctor's office and handing them $20 to be seen. But there are plans with these embedded that can have still a 180/50 breakdown and still have a copay each visit. And then on top of that, they can have a maximum number of copays. Okay? So you have to keep this in mind because our software is not designed for this. Okay? We are not designed or set up at all in order to have copays. And I know that eventually they may get there, but this is definitely making it difficult.
Then we have to discuss it.
So then we have the embedded plans. I'm going to give you an example here of what it looks like on a visual, okay? So what we have is this is going to show you a standalone low, a standalone high, and then an embedded with medical for a total of a $617 out of pocket and how it looks different. So, for example, in a standalone low, out of $617, the child may pay $203, and the insurance will pay $414. On the standalone high, their out of pocket is $168, and the plan pays $449. On the embedded, they pay the whole thing. Again, because of one of those embedded plans with that high maximum. So you can have patients that are going to walk in the door and be all excited because they have dental now for their kids, and you're the one that has to explain to them they do, but they still have to pay for their visit. And I don't know about you, but a lot of these patients that were already, not coming because they couldn't afford it, they still can't afford it. They're still paying out of pocket. So this is where the embedded gets very difficult. So here's some fun, and this is something I actually had another phone call regarding this today. So this is going to be, I'm going to give you a little history on this. So here you have, and the history is I had a patient who needed a crown done, replacing an onlay that was over, I want to say 14 years old. We had done it in our office, so I knew how old. Sent my 3D out to Delta. 3D comes back. I get my 2 copies because they usually send 2 copies, and I go to take care of the pre-authorization, and I look and I bring it out and it says Delta pays $0. So I go down here and it says the patient exceeds program's age limit. So now I'm confused because they can do this. This is not a plan. I know that it's over 10 years old. There's no reason for them to say no. So I pick up the phone as usual. I get on to go to talk to Delta, and I pull out the second sheet that I was given, and I see this. And I see, wait a minute, now they're paying. They're paying $424.50. Well, how are they doing that? The last slide just told me they're paying nothing. So this one's $0. It turns out that this employee had an embedded dental plan that he knew nothing about. He had no idea he had it. And in Delta's wisdom, they are not only signing up the children on these plans, they're signing up everyone in the family, and then internally coordinating this, and then saying, oh, wait, he's too old for it. So you're going to start getting denials that don't make any sense to you because your patient doesn't even know you had it. Now, to add to this, something happened with this same exact family today. I was at work this morning, and I was calling to find out why his daughter's insurance didn't pay me for a cleaning from 3 months ago. So I called, and they start looking at why, and she says to me, well, it looks like there might be an issue. Oh, wait, no, there's two insurances here. The woman at Delta didn't even know that the second plan was embedded. She had no notification. There's nothing telling them on that end. And then it turns out that they have separate ID numbers. So I have new ID numbers for both plans that I'm supposed to be using, but the patient hasn't been told this. There's an ID number for embedded dental plan that the patient doesn't know anything about. So I followed it up one step further to double check who's primary. Is the traditional dental insurance plan primary, or is the embedded plan primary? Because I see that as my next headache. And it turns out, for your own information, at least with Delta, they are going by effective date between the two insurances. So if they have dual insurance and one of them's an embedded plan, whichever was first is what, at least is Delta, that's who's primary. But this is another question I think I'm going to add to my list of questions that we're going to get to be asking the insurance companies when we're calling. So what's in your state? This is a list, and I went through. There's 22, I think it's 22 in that have their own. So take a snapshot of this, or after the webinar, you can email me, and I'll send this over to you. But this is where you go, okay? If you don't see your state on here, you go to the top, the one at the top. So you go to healthcare.gov marketplace in your state. I did my best to make these links go straight to where the dental is. If I didn't succeed, I apologize. Some of these websites are very, very difficult to maneuver and to get to, and your best bet might be a phone call. In Vermont, you have it easy. There's one insurance company. It's Delta Dental. So the states are very, very different, okay? And here's just a little snapshot of it. Vermont has only one insurance company. New York State has all three, standalone, bundled, and embedded. And Kansas is 100% embedded plans. I'm sorry for any of you that are in Kansas, because it's going to make life, I think, very difficult. So future discussions are what are happening. Right now, this is kind of a snapshot of how different rules and how they apply to the Affordable Care Act, the plan design, the company plan design in the center is your traditional plan, okay, and then you're embedded. So as you look, you can see that your standalone and bundled have the 70 to 85 AV. What I found interesting was that the company traditional plans are typically an 85% actuary value or higher, okay, and then embedded can vary. You have your maximum out of pocket. Your deductibles under the Affordable Care Act plans can change, okay? They can vary. They can be anywhere from 25 to 50, same as your traditional. Your embedded can be combined with your medical, okay? So again, that phone call about, when you go to the next line about the regulations, you have stricter regulations than embedded. The embedded can be anything across the board. You can pay for a platinum level plan, but there's no assurance that your dental part of that plan is going to be anything better than a bronze. So your patients may not even know. And in some cases, there's no way for them to find out until they buy the plan. Okay, the Affordable Care Act has no annual maximum for children, but our traditional plans usually do. So another quick sample. I tried to find a few different samples across the country to show you just little snapshots. So we have the Northeast Delta Dental. You have, this is both adult and children, but if you look down at the bottom, there is a maximum for each enrollee over the age of 21, and there is a waiting period over the age of 21 for some. So, again, it states that your maximum out-of-pocket is $350 per enrollee under the age of 21. And then, again, if you look, we were talking about, I'm going to see if I can highlight this. Only expenses incurred for covered services received by, by a Delta Dental PPO dentist accrue toward the maximum out-of-pocket. So you have to be an in-network dentist in order for that to occur. Otherwise, it doesn't work for them. Okay? So there's nothing that's going to help them. In Minnesota, I found a plan that's through Dentagra, and Dentagra's in this area too. So it had a little bit different. So this is one I put up because I felt that it had some differences to it that were important to note. So this has an adult in-network deductible of $50, but the kid is 65, which I found odd. There are pediatric services for everything through major, but adults there's none. Okay, and the other thing with this is this one again, you can get out-of-network benefits, but they're only going to pay up to the contracted amount, and it's not going to go towards their maximum out-of-pocket. And then Maryland. Maryland had a plan that is a basic plan that's similar to the DMOs, and there's co-pays per visit. Okay, so there's different types out there, and there was probably 100 different types that I could have picked for this. So we're a very fluid landscape. Okay, and this is some samples I got. I got this information direct from Delta Dental. A gentleman by the name of Jeff Album has been a great help to me in getting this information to you. So in 2015 and 2016, on average, 43% of all qualified health plans, QHPs, insurers embedded in some form or other. And then there's changes on the state level. These were the most important ones that he found. Arizona went from 36 embedded in 2015 to 66. Florida went down from 58 to 30. Kansas went from 20 up to 100. And that was due to 3 that were exiting the Kansas market. Ohio went from 66 to 31, but it also jumped how many insurers it had. It went from 6 to 16. New Hampshire went from 100% down to 40. And then Pennsylvania went from 50 to 80. Again, this is fluid and this is changing daily. And my next slide will tell you how much I mean by daily. Yesterday, I got an article sent to me that the largest U.S. insurer pulled out of 2 states as of yesterday, United Health Group. In New York State, Health Republic went bankrupt halfway through the year last year, and people lost their coverage. Just remember, this is a changing and very, very fluid field. So what do you ask? I came up with some things of what I feel can help you as you call. Most of us have our standard list of what we call for our traditional insurances. I tried to break this down the same way. So obviously, it seems obvious, but one of the first questions would be, is this embedded, standalone, or bundled? This helps you understand the rules. Is a deductible separate for medical or dental? Probably the most important is preventive subject to the deductible before coverage. Okay? And are kids covered different than children? Like I said, I have that one that they signed him up, but he's not even covered. Where do we send the bills? How do we bill it? Can it go on dental? A dental doesn't need to go on a medical form. Do they pay to the dentist? And do you have to be in network for us to be paid in the dental office? There's a lot of plans out there that are going to be, you have to be in network, and it's increasing. And then is there a cap on the copays per visit if there are? Now, something else I learned today, because I am learning something every day, is that in certain plans, in certain cases, if you have not informed the patient of their out-of-pocket costs per your agreement, you may not balance bill them. So let me say that again. If you have not informed them of any out-of-pocket costs ahead of time, you cannot bill them. You've agreed to that. And there is a plan in New York State called HealthFlex. Thank you, Judy, for that info if you're on the call, that this is part of the contract. So there's a lot of offices not willing to join because of that. So why should we join? Why would you even want to open that can of worms? Well, First of all, what plans are in your area, and how is it changing? Who's covered? What does your patient base look like? Are you getting a lot of phone calls saying, hey, do you take such and such? Are there out-of-network benefits, or are they no longer available in your area? What are your patients' needs? So I feel that participation is a very personalized to your practice decision, that you need to really take a look at what's around you. But I'm going to give you an example of some of what can happen to all of us. Last October, let me back this up. The office I work for is a fee-for-service office. We accept about 4 to 5 insurance plans in my regular general practice. I also work with a prosthodontist. She accepts, up until this year, no insurance. She does not participate with anything. Last October, it was announced by Independent Health that does Medicare supplemental care for our seniors in this area. Up until January, their supplemental dental went through Delta Dental, which paid whether you were PPO or Premier, and they could go out of network, and it was fairly simple. They changed that plan to a company called HealthPlex that you had to be participating with. So anybody who's on the call that's in the Buffalo area, you know there was a massive scramble to either A, sign up, or D, decide if you needed to. So with both my doctors, I had to sit down. I had to analyze what the needs were, and do we need to participate? And in this case, my doctor, my prosthodontist, in order to care for her patients, took the first plan ever that she's participated with in all the years that she's been in practice. So this is something that you need to personalize for your office. So what did we learn? I hope you learned something today. But what I feel that I taught was that insurance is an ever-changing field. You need to ask questions. I gave some pointers on how to ask them. You learned the difference between standalone, embedded, and bundled. You learned some new words. Maybe didn't want to, but you learned some new words. We'll get to EPO, that's coming up, AV, EHV, embedded, and marketplace. You learned what some of the new plans look like and some reasons that you may want to participate. So I'm just going to take a minute to go through 2 other trends, and then we'll open up to any questions. If you do have any questions, please send them in the chat field, and we'll try to get to them, okay? So there are 2 trends that I feel it was important to bring up and I didn't want to do today without talking to you about. And the first is EPO, Exclusive Provider Organization. Learn the term, okay? Delta Dental are selling these plans throughout the entire country, and I did verify that with one of my reps. And these are plans that you have to go to a participating dentist. So they can still choose where they go, but the office has to participate. There are no out-of-network benefits. So for an office like mine, we're strictly Premier Delta Dental, we can't take these plans. I can't see these patients. They will pay absolutely nothing for them out of network. And from what I understand, this is a new trend that's going to be brought up, and there are other insurance companies out there starting to offer these. I don't have enough solid evidence to say who they are. So once I do hear it, I will let it known. But for now, Delta is definitely selling them around the country. The other thing I'm seeing are the DMOs, the dental maintenance organizations. When I first started, I don't like to say how many years ago, as a manager, about 15 years ago when I moved back to Buffalo, the DMOs were pretty solid. There was a good number of them here. That seemed to go down, and what I've noticed is in the last 4 to 5 years, they're coming back, okay? I must have gotten at least 10 phone calls, and I'm not a huge practice, but 10 phone calls in this area for people that were being offered a Cigna DMO. Now, their employer had a choice. They could pick one or the other, but it is making a comeback, or I feel it's starting to come back. So just be aware and make sure that you're paying attention to what's going on in your area. Before I open it up for questions, I just want to give a thank you to both Jeff Album and Frank Reynolds of Delta Dental and Roberta Rifkin from Independent Health provided me with some really great information, some of the slides and a lot of the questions that I had, they helped answer. Marnie Feinberg helped me make my slides look as pretty as they did. I'd like to thank One Mind Health, who was the original host, and due to unfortunate circumstances wasn't able to. And then thank you to Ikram and MVP for picking up and letting this still happen. So if you do have questions, I'm going to try to go through. Okay, so I have a question here from Cindy that says, my office will participate in a reduced fee plan.
They're in a different spot.
But we need to sign up for the plans where they pay full fee. The reduced fee plans, you want to steer clear of those, but a reduced fee plan is strictly they pay for it themselves. If it's a plan that they pay full fee out of network, you typically don't need to sign up other than sending the I-9 form that they require. I hope that answered that question. Viewer number 12, I don't get how EPO and DMOs are different. The DMOs you're assigned to an office. You're assigned to your practice. You are assigned specifically to that patient's assigned to you. The EPO is similar to a PPO, but they have to go to an in-network dentist or there's no benefit. As opposed to in the past or as the setup now, a PPO insurance, you can still go to any dentist and they will pay out of network. They just may not pay as much. But the EPO, they will pay nothing. So, okay. So a network versus a specific office. That's correct, yes. Yes, viewer 12, I don't know who that is. Yes, it's a network, not a specific office. So you have a network of dentists that are part of the EPO or the PPO. You can go to any of them, but the DMO, you have to go to the doctor you're assigned to. And then Barbara asked, when you spoke, they stated that the EPOs, they can go to the dentist of their choice. They can go to the dentist of their choice that is on the plan, Barb. They have to be signed up as either, and I believe most of the EPO plans are pulling from the PPO network already. So if you are a Delta PPO, you are part of those. But from what I'm being told, they may be coming out with a new, and I don't know if it's going to be a fee schedule, I assume it is, but they're going to be coming out with new information and new contracts, and there might be some that they're signing them on that way. So thank you, Cindy. I'm grateful that you joined us, and I'm glad I hope you learned a lot. Any other questions out there? I'm sure you have some. Let's see. Hang on. Over here? Okay. So I'm just trying to figure out if there's any other questions that we have. So just remember my contact information. I'll give you that. Hang on, I hit a button wrong.
Judging from the time, I would say yes.
Okay, so again, I'm Colleen Huff. My dental insurance lady.weebly.com site is working. The Colleen Huff one right now is not up to date. And if you need to reach me, you can also find me at dentalinsurancelady@gmail.com.
Sounds good. We'll be right up for you. Okay, thank you. You're welcome.
Viewer number 33, yes, I am recording this. What I'll try to do is send it out. I'm going to try to figure out a way to post it on my website. And if not, I will try to send a link. And MVP is going to put it on their website also. So you'll be able to find it on MVP Works. Handouts, if you want to shoot an email to me at dentalinsurancelady@gmail.com, I will be able to make some of them available and send them out to anyone who's interested. That way you can have the information at hand.
I gotcha.
If there's any... You're welcome, number 12. It doesn't have names. I apologize. And 33. And ladies and those of you that do know me, thanks so much. And Barb, yes, your head is spinning. I understand that. There was just a comment that from one of the people on that her head is spinning. I understand that, and there's actually was a lot more I probably could have given, and I tried to scale it back because it makes your head hurt after a while. So I will continue to try and monitor this, and I'm hoping to do this every year because of the amount of information that's changing and how quickly it's something that I think we're going to all have to keep up on.
This is Ikram again. Want to thank everybody for their time. We are going to, like Colleen said, we're going to have a recording of this webinar posted. I'd recommend listening to it 2 to 3 times so that you can grasp everything. It's going to take some time for it to sink in. Again, we're MVP Network Consulting. You can reach us at mvpworks.com or 1-855-MVP-WORKS. Again, mvpworks.com. Thank you very much, everybody. I hope you guys enjoyed it, and have a great day. If you need any IT help, give us a call. Thank you.
Any further questions before I sign off? Most of you know where to find me, and if not, you can always go to also the ADAM website and go to the Buffalo Western New York chapter. My information is there. I can answer that, too, if you lose any of this information. Okay?
Thank you, everybody.
Thank you, everybody.